The year is 1996. You're 17 years old. You've just torn your ACL during a championship soccer game, the kind of injury that hurts so badly you can't think, can't breathe, can't do anything but clutch your knee and wait for the trainer to arrive. The surgery is routine, successful. The orthopedic surgeon, a professional you trust, whose diplomas line the walls of a clean, modern office, hands you a small orange bottle, 60 tablets, Percocet, 10 milligrams each, 1 to 2 every 4 to 6 hours as needed for pain. You take the first pill that night. Within 30 minutes, the pain softens, but something else happens too. The anxiety about your scholarship, about returning to play, about your grandmother's recent death, it all fades. You feel warm, safe, better than you felt in months, maybe better than you've ever felt. 2 weeks later, the bottle is empty. The surgeon gives you 30 more. He tells you this is the last refill. Transition to Tylenol, he says. You try, you really do. But 36 hours after your last pill, you feel terrible, anxious, aching, unable to sleep. You don't connect it to the pills, not yet. 3 years later, you'll die of a fentanyl overdose in a friend's apartment. You are not alone. You are one of hundreds of thousands. And it all started with a prescription from a doctor, for pain that was real. This is the disturbing truth about how doctors created drug addicts. And it's a story that reaches back more than a century, through morphine and heroin, through corporate greed and regulatory failure, through good intentions twisted into catastrophe. This is history for sleep, and you need to hear it. Before we begin, if you're new here, welcome. This channel is dedicated to long-form historical content designed to help you sleep, learn, or simply escape for a while. The topics are dark, often disturbing, but always real. History doesn't sugarcoat itself, and neither do we. If you find this content valuable, please consider subscribing. Hit the like button if you appreciate the research that goes into these videos, and drop a comment. Let me know what historical topics you'd like covered next. Your engagement genuinely helps this channel grow. Tonight's topic is the opioid epidemic in America, specifically how the medical system itself created the largest drug addiction crisis in modern history. We'll trace the path from 19th century morphine to Percocet, OxyContin, heroin, and fentanyl. We'll examine the corporate decisions, the regulatory failures, the financial incentives, and the individual tragedies. This is a 90-minute deep dive. Get comfortable, dim the lights, and let's begin. To understand how we arrived at an epidemic that has killed over 700,000 Americans, we need to go back to a time when opium was sold openly in pharmacies, when morphine was hailed as a miracle, and when heroin was marketed as a safe cough suppressant. The year is 1803. A German pharmacist assistant named Friedrich Serturner isolates a crystalline compound from opium poppy resin. He names it morphine, after Morpheus, the Greek god of dreams. It is 10 times more potent than raw opium, and it works. For the first time in human history, severe pain can be reliably controlled with a measured dose of a purified substance. By the 1850s, morphine is everywhere. The invention of the hypodermic needle in 1853 makes administration easier, faster, more effective. During the American Civil War, morphine becomes the standard treatment for battlefield injuries. Soldiers are given morphine for gunshot wounds, amputations, dysentery, anything that causes suffering. It is called God's own medicine. It saves lives. It makes the unbearable bearable. But it also creates addicts. By the end of the Civil War, hundreds of thousands of soldiers return home dependent on morphine. The condition is so common it earns a name, soldier's disease. These men, and the women who cared for them, are trapped in a cycle they don't fully understand. There is no detoxification, no treatment, no support system, just a craving that never ends in a society that doesn't yet have the language to describe addiction. Throughout the late 19th century, opiates are everywhere in American life. You can buy laudanum, a tincture of opium and alcohol, at any pharmacy, no prescription required. It's marketed for everything: teething pain in infants, menstrual cramps, coughs, insomnia, anxiety, depression. Patent medicines with names like Mrs. Winslow's soothing syrup and McMunn's elixir contain opium, morphine, or both. No labels are required, no warnings are given. Mothers dose their babies, workers take it to get through long shifts, the elderly use it for chronic pain. Addiction, when it's recognized at all, is called habituation. It's seen as a moral failing, a lack of willpower. The medical community understands dependency exists, but they don't fully grasp the mechanisms, and they certainly don't Stop prescribing. Then, in 1898, the Bayer pharmaceutical company in Germany synthesizes a new compound. It's derived from morphine, but modified chemically to be more potent, faster acting. They call it heroin, from the German word heroisch, heroic. It's marketed as a non-addictive substitute for morphine, a cure for morphine addiction, a safe cough suppressant for children and adults. This is not marketing stunt. This is what Bayer's chemists genuinely believed, and for a brief time, the medical community accepts it. Heroin is prescribed widely. It's available over the counter. Advertisements show children taking it for coughs. It's recommended for asthma, bronchitis, tuberculosis. But within a few years, the reality becomes undeniable. Heroin is not safer than morphine. It's more addictive. The dependency develops faster. The withdrawal is worse. By 1910, hospitals in major American cities are overwhelmed with heroin addicts. The drug that was supposed to cure morphine addiction has created an even larger crisis. In 1914, the United States passes the Harrison Narcotics Tax Act, the first federal law regulating opioids. It doesn't ban them outright. It requires registration, taxation, and record-keeping for anyone who manufactures, imports, or distributes opiates. Doctors can still prescribe them, but the law is vague about what constitutes legitimate medical use. The enforcement is harsh. Doctors who prescribe opioids to maintain addicts, essentially what we would now call medication-assisted treatment, are arrested, prosecuted, imprisoned. Thousands of physicians are charged. Some lose their licenses. Some go to jail. The message is clear. Addiction is a criminal problem, not a medical one, and doctors who help addicts are criminals. This creates a black market. Heroin, now illegal for most purposes, moves underground. Organized crime takes over distribution. Purity becomes unpredictable. Prices rise. And addicts who might have been maintained on legal prescriptions in a controlled medical setting are forced into a criminal world where overdose, violence, and incarceration are constant threats. For much of the 20th century, this is the landscape. Opioids are dangerous, addictive, tightly controlled substances. Doctors are cautious. Prescriptions are rare, reserved for severe acute pain, post-surgical recovery, traumatic injuries, terminal cancer. Pain, even significant pain, is often undertreated. There's a pervasive belief that patients should endure a certain amount of suffering, that it's better to be too conservative than too liberal with these medications. And then, in 1976, a pharmaceutical company called Endo introduces a new product. It's not revolutionary. It's just oxycodone, a semi-synthetic opioid derived from thebaine, a component of opium, combined with acetaminophen, the active ingredient in Tylenol. The brand name is simple, memorable, almost friendly: Percocet. Acetaminophen is perceived as safe. It's over the counter. Parents give it to children for fevers. The psychological impact of pairing a powerful opioid with something as benign as Tylenol cannot be overstated. It makes the medication feel less dangerous, more acceptable, more like ordinary medicine rather than a controlled substance with a dark history. For nearly 2 decades, Percocet occupies a middle ground. It's prescribed conservatively. Doctors monitor patients. Refills are limited. The system, such as it is, functions. Percocet is unremarkable. It doesn't make headlines. It's just a medication, doing what medications are supposed to do. But beneath the surface, something is shifting. A new philosophy about pain is taking root, one that will change everything. It begins, as many catastrophes do, with good intentions. Throughout the 1980s and early 1990s, a growing movement of physicians, patient advocates, and researchers argues that pain is being undertreated in America. They point to cancer patients dying in agony because doctors are too afraid to prescribe adequate opioids. They highlight studies showing that patients in severe pain are often dismissed, their suffering minimized. They call for a revolution in pain management, a fundamental rethinking of how medicine approaches one of humanity's most universal experiences. This advocacy is not without merit. Pain is indeed undertreated. The medical community's fear of opioids, born from the disasters of heroin and morphine, has went too far in the opposite direction. Patients are suffering needlessly. Something needs to change. But what begins as well-intentioned advocacy soon morphs into something else entirely. It becomes a vehicle for pharmaceutical propaganda on a scale the world has never seen.
In 1986, a prominent pain specialist named Dr. Russell Portnoy publishes a study that will become one of the most consequential pieces of medical literature in modern history. Portnoy claims that the risk of addiction in pain patients treated with opioids is less than 1%.
The implication is clear. When opioids are prescribed for legitimate pain, addiction is virtually impossible. The study is deeply flawed. The sample size is small. The methodology is questionable. The conclusions far exceed what the data actually shows. But none of this matters. The pharmaceutical industry has found its golden ticket. Portnoy's claim spreads through medical conferences, journal articles, and educational materials. It's repeated so often that it becomes accepted truth. Years later, Portnoy will publicly recant, admitting that he gave physicians a false sense of security, but by then, the damage is irreversible. The institutional changes come rapidly. Throughout the 1990s, the Joint Commission on Accreditation of Healthcare Organizations, the body that accredits American hospitals, begins mandating pain screening as a standard part of patient care. Then, in 1999, the Department of Veterans Affairs adopts a policy that will echo through the entire healthcare system. Pain is to be assessed as the fifth vital sign, alongside blood pressure, heart rate, respiratory rate, and temperature. This is not merely a suggestion, it is policy. Treating pain becomes as fundamental as monitoring a patient's heartbeat, and failure to aggressively treat pain can be interpreted as substandard care, even malpractice. Into this shifting landscape comes Purdue Pharma, with a product that will reshape American medicine and American society. In 1996, the company launches OxyContin, a controlled-release formulation of oxycodone designed to provide 12 hours of continuous pain relief. The doses are unlike anything previously seen: 10 milligrams, 20 milligrams, 40 milligrams, 80 milligrams, and eventually 160 milligrams of pure oxycodone in a single tablet. These are massive, previously unthinkable doses. An 80 milligram OxyContin tablet contains more opioid than most patients would have received in an entire day of hospital care just a decade earlier. But Purdue insists the medication is safe, that the controlled release mechanism makes it less prone to abuse, less likely to cause addiction. At the center of Purdue's marketing campaign is a lie, a deliberate, calculated, carefully constructed lie that will cost hundreds of thousands of lives. The company claims that the risk of addiction with OxyContin is less than 1%. They cite Portnoy's work, but they also rely on something even more tenuous, a single paragraph from a 1980 letter to the New England Journal of Medicine. The letter, written by two researchers, notes that among nearly 12,000 hospitalized patients treated with opioids for acute pain, only 4 cases of addiction are documented. This is a letter, not a study. It involves hospitalized patients receiving carefully monitored short-term treatment for acute pain in a controlled medical setting. Purdue takes this single paragraph and twists it into a sweeping generalization about chronic pain treatment in outpatient settings, a context for which the data is utterly irrelevant. They build an empire on a foundation of sand. What follows is the most sophisticated pharmaceutical marketing campaign in history. Purdue more than doubles its sales force, deploying thousands of representatives across the country. But they don't focus on pain specialists or oncologists, doctors who already understand opioids. They target primary care physicians, family practitioners, general internists. These are doctors with the least training in addiction medicine, the least experience with long-term opioid prescribing, and the largest patient populations. The sales representatives come armed with misleading charts, biased studies funded by Purdue itself, and a powerful psychological weapon: moral guilt. They tell doctors that undertreating pain is a failure of compassion, that allowing patients to suffer when effective treatment exists is unethical, that the old fears about opioids are outdated, disproven by modern science. The financial incentives are staggering. Sales representatives receive bonuses based on prescription volume. The more OxyContin their assigned doctors prescribe, the larger their paychecks. Doctors who are willing to prescribe high doses in large quantities are rewarded with speaking fees, sometimes $5,000 to $25,000 per presentation. They're invited to all expenses-paid pain management seminars at resort locations where they're wined, dined, and educated by materials created and funded by Purdue. Purdue distributes branded promotional items with a cheerfulness that now seems obscene: fishing hats emblazoned with the OxyContin logo, compact discs titled "Get in the Swing with OxyContin," plush toys. They fund continuing medical education courses, the very courses doctors are required to take to maintain their licenses, ensuring that the lessons being taught align with Purdue's messaging. And that messaging is reinforced by the policy changes already in motion.
Pain as the fifth vital sign creates immense pressure. If treating elevated blood pressure is mandatory, then treating pain is mandatory. Allowing a patient to remain in pain is no longer a judgment call. It's a failure, potentially actionable. Meanwhile, Medicare and Medicaid begin tying reimbursement rates to patient satisfaction scores, and patients, unsurprisingly, are more satisfied when their pain is aggressively treated, when they walk out of the doctor's office with a prescription that promises relief. The result is an explosion in opioid prescribing unlike anything in medical history. OxyContin sales go from $48 million in 1996 to over $1 billion by 2000. 4 years, a 20-fold increase. Purdue's profits soar. The Sackler family, which owns Purdue, becomes billionaires many times over. But OxyContin is not the only beneficiary of this revolution. Percocet, generic, established, familiar, rides the same wave. While OxyContin grabs headlines and attention, while Purdue becomes the public face of aggressive opioid marketing, Percocet quietly becomes one of the top 10 most prescribed medications in the United States. Doctors who might have hesitated to prescribe OxyContin, that new drug with the high doses and aggressive marketing, have no such reservations about Percocet. It's been around for decades. It seems moderate, reasonable. And in the new culture of pain management, where treating pain is not just encouraged but mandated, where undertreating pain could mean professional consequences, prescribing Percocet feels like the safe, responsible choice. The prescriptions flow, not just for severe pain, not just for post-surgical recovery, but for chronic back pain, for dental work, for minor injuries. The 3-day supply becomes a 30-day supply. The 20-tablet prescription becomes 100 tablets. Refills that had once been scrutinized are now routine. By the late 1990s, the floodgates are open, and Americans, trusting their doctors, trusting the system, walk straight into the trap. The decade that follows, from 2000 to 2010, marks the peak of the prescription opioid era. This is the time when these medications cease to be carefully controlled substances and become something else entirely, ubiquitous, routine, almost mundane. Percocet, Vicodin, and OxyContin are prescribed not just for severe pain, but for minor injuries, a sprained ankle, chronic back pain, dental work, wisdom teeth removal in teenagers who receive a month's supply for a procedure that causes discomfort for perhaps 3 days. By the middle of the decade, American doctors are writing more than 250 million opioid prescriptions per year, enough for every adult in the country to have their own bottle. But the prescriptions themselves tell only part of the story. What emerges during this period is something more sinister, more organized, more explicitly criminal. They're called pill mills. Florida becomes ground zero. Throughout the state, but particularly in South Florida, cash-only pain clinics open in strip malls and office parks. These are not legitimate medical practices. They're drug distribution centers operating under the thinnest veneer of medical legitimacy. Patients, though that word hardly applies, line up outside before dawn, sometimes 100 or more in a single day. They pay $200 to $300 in cash for a 5-minute consultation with a doctor who asks no meaningful questions, performs no genuine examination, and writes prescriptions for hundreds of pills. The most notorious of these operations is a clinic called American Pain, located in Fort Lauderdale. Between 2008 and 2010, before it's finally shut down by law enforcement, American Pain distributes approximately 20 million oxycodone pills. 20 million pills in 2 years from a single storefront clinic. The doctors who work there become wealthy, the owners become millionaires, and thousands of patients become addicts or die. But American Pain is not unique. Similar operations flourish in Ohio and West Virginia. Small-town pharmacies in rural Appalachia fill prescriptions that exceed the population of entire counties. One pharmacy in a West Virginia town of 400 people dispenses over 9 million hydrocodone and oxycodone pills in just 2 years. The numbers are impossible, absurd, and yet they're real. Internal documents later reveal that Purdue Pharma knows what's happening. The company tracks prescribing patterns, identifies doctors who are writing suspiciously high volumes of prescriptions, and in some cases flags them as potential problems. But the company does not stop marketing to these doctors. In many cases, sales representatives are instructed to increase their attention to high-volume prescribers. The money is too good. The growth is too intoxicating. The human cost of this flood is catastrophic. Addiction spreads through white rural America with a speed and intensity that shocks communities unprepared for such
devastation. Appalachia is hit hardest, a region already struggling with economic despair, the collapse of coal mining, the loss of manufacturing jobs. The opioid epidemic finds fertile ground in that despair. Towns are hollowed out. Emergency rooms are flooded with overdoses. Families disintegrate. Percocet plays a central role in this disaster, though it often receives less attention than OxyContin.
In 2010, Purdue reformulates OxyContin to make it more difficult to crush and snort, adding abuse-to-turn properties. But Percocet and its generic equivalents remain easy to manipulate. The tablets can be crushed, dissolved, injected. And because Percocet is a familiar brand, available in multiple strengths, it becomes a kind of currency on the street. The economics are straightforward. A single Percocet 10 milligram tablet can be sold for $10 to $15, depending on location and availability. Lower strength pills go for $5 to $8. For people with legitimate prescriptions or who can obtain them through doctor shopping, the profit potential is enormous. Get a prescription for 90 tablets at a copay of $10 or $20, then sell them for $900 to $1,350. The incentive for diversion is overwhelming. The methods of diversion become increasingly sophisticated. Doctor shopping, visiting multiple physicians to obtain overlapping prescriptions, is common until prescription monitoring databases begin tracking such behavior. Forged prescriptions proliferate. Pharmacy robberies increase. And perhaps most tragically, grandchildren steal pills from their grandparents' medicine cabinets, beginning their own descents into addiction with medication prescribed for arthritic pain or post-surgical recovery. From 2006 to 2012, Percocet and its generic equivalents are consistently among the top 10 most prescribed medications in the United States. Not the top 10 pain medications, the top 10 medications, period. In 2009 alone, doctors write 58 million prescriptions for oxycodone combined with acetaminophen. To put that in perspective, that's nearly one prescription for every 5 Americans, including children and the elderly. The systems that are supposed to prevent this, medical oversight, pharmacy vigilance, law enforcement, have been overwhelmed or corrupted. Doctors face pressure from patient satisfaction scores, fear of undertreating pain, and in some cases, simple greed. Pharmacies profit from every prescription filled. Distributors profit from every shipment. And at the top of the pyramid, pharmaceutical companies count their billions. In 2007, Purdue Pharma pleads guilty to federal charges of misbranding OxyContin, admitting that the company had falsely claimed the drug was less addictive and less subject to abuse than other opioids. The fine is $600 million. It sounds substantial until you realize that Purdue has already made tens of billions from OxyContin sales. The fine is in essence a cost of doing business. The drug remains on the market. The prescriptions continue. It's during this period that the demographics of the crisis begin to shift in ways that finally capture media attention. For decades, when drug addiction ravaged Black urban communities, first heroin in the 1960s and 70s, then crack cocaine in the 1980s and 90s, the response had been criminalization, mass incarceration, and moral condemnation. Addiction was framed as a personal failure, a character flaw, a choice. But the opioid epidemic is different. It's affecting white, middle-class suburban communities. It's affecting the children of doctors, lawyers, teachers. And suddenly the narrative shifts. Addiction becomes a disease, something requiring treatment and compassion rather than punishment. The racial double standard is stark and undeniable. West Virginia, Ohio, and Kentucky are hit hardest of all. These are states already struggling with economic decline, regions where coal mines have closed, factories have shut down, and opportunities have evaporated. Young people see no future. Middle-aged workers face chronic pain from years of physical labor with no prospect of retirement. Into this environment of economic despair comes an endless flood of opioids, prescribed by doctors, dispensed by pharmacies, tacitly approved by a healthcare system that prioritizes patient satisfaction and pharmaceutical profits over patient safety. The combination is a perfect storm. Pain, both physical and existential, meets a chemical solution that's legal, doctor-approved, and readily available. The pills promise relief, and they deliver it at first. But the relief comes with a price that millions of Americans are only beginning to understand. By 2010, the crisis is undeniable. The overdose deaths are mounting. The addiction rates are astronomical. The human wreckage is everywhere. But even as awareness grows, even as the first reforms begin, the damage has been done. An entire generation has been
introduced to opioids through the most trusted channels in society: their doctors, their pharmacies, their healthcare system. But as prescriptions begin to tighten, as scrutiny finally comes, the addicted don't simply disappear, they evolve, and the pills that started it all become a gateway to something far deadlier. The period from 2010 to 2015 marks a catastrophic transition in the American opioid epidemic. Law enforcement and regulatory agencies, finally recognizing the scale of the disaster, begin implementing aggressive crackdowns. Doctors are arrested. Pill mills are raided and shut down. States implement prescription drug monitoring programs, databases that track who is prescribing what to whom, making doctor shopping far more difficult. The flow of pills begins to slow. These are necessary interventions. They should have happened years earlier, but they come too late for millions of Americans who are already addicted, already dependent on a daily supply of opioids just to function, just to avoid the agony of withdrawal. And when the prescriptions dry up, these people have nowhere to turn. The medical system that created their addiction offers no real solutions. Very few doctors are willing or able to provide medication-assisted treatment. Detoxification programs have long waiting lists and are often prohibitively expensive. So the addicted do what desperate people have always done. They find another way. The economics of that transition are brutal and simple. A single Percocet pill on the street costs $10 to $15 and provides perhaps 4 hours of relief. A small bag of heroin costs $5 and delivers the same effect, sometimes stronger and longer lasting. For someone who needs multiple pills per day just to avoid withdrawal, let alone to feel high, the math is undeniable. Heroin is cheaper, more available, and increasingly easy to find. The shift is accelerated by a single corporate decision. In 2010, Purdue Pharma reformulates OxyContin to include abuse-deterrent properties. The new tablets turn into a gummy, uncrushable substance when tampered with, making it nearly impossible to snort or inject. This is presented as a public health victory, a responsible action by a company trying to address the crisis it helped create. But it has an unintended consequence. Users who had been crushing and snorting OxyContin don't simply stop using opioids, they switch to alternatives. And the most readily available, most economically viable alternative is heroin. The data tells a stark story. According to the Centers for Disease Control and Prevention, 4 out of 5 new heroin users, 80%, start with prescription opioids, primarily Percocet, Vicodin, and OxyContin. These are not career criminals or hardened addicts from broken homes. These are people who trusted their doctors, filled legitimate prescriptions, and found themselves trapped in a cycle of dependence they never anticipated. The demographic shift is shocking. White suburban teenagers are injecting heroin in high school bathrooms. College students are overdosing in dorm rooms. Mothers are using in minivans parked outside grocery stores. Veterans who had been prescribed opioids for combat injuries are dying with needles in their arms. These are populations that historically had never touched heroin. It had been an inner city problem, a problem associated with poverty and crime and urban decay. Suddenly, it's everywhere. Mexican drug cartels, recognizing the massive and growing market, flood the United States with heroin of unprecedented purity. Historically, street heroin had been 20 to 30% pure, cut with various adulterants to increase profit margins. But the new supply is often 50 to 90% pure. Users accustomed to weak heroin are suddenly injecting product that's 3 or 4 times stronger. The result is predictable. Between 2010 and 2015, heroin overdose deaths in the United States quadruple. In 2010, approximately 3,000 Americans die from heroin overdoses. By 2015, that number has climbed to nearly 13,000. And this is just the beginning. Percocet maintains its role as a starter drug throughout this transition. While OxyContin has become difficult to abuse after its reformulation, Percocet and its generic equivalents remain crushable, snortable, and relatively easy to obtain. For many users, the pathway is clear. Legitimate prescription for an injury or surgery, increasing tolerance, growing dependence, prescription ends or doctor refuses refills, turn to buying pills on the street, economics become unsustainable, introduction to heroin by a friend or dealer, first time smoking or snorting it, then eventually injection when even that stops working. What makes this transition particularly tragic is the way the medical system abandons the people it has addicted. When doctors finally become afraid to prescribe opioids, when the regulatory scrutiny increases and the risks become too high, they don't taper them.
Patients gradually or refer them to addiction treatment. They simply cut them off. Cold. No follow-up, no support, no plan. Just a refusal to refill prescriptions. For someone physically dependent on opioids, sudden cessation means withdrawal. And opioid withdrawal, while not typically life-threatening, is utterly unbearable. Imagine the worst flu you've ever had multiplied by 10, combined with crushing psychological despair and the absolute certainty that you cannot endure another moment of it. Now imagine that the only cure, the only thing that will make it stop, is readily available on the street corner for $5. The choice for millions of Americans isn't really a choice at all. The stigma around injection drug use, which had been a powerful barrier for decades, begins to break down under the weight of desperation. People who had sworn they would never use heroin find themselves using heroin. People who had sworn they would never inject anything find themselves learning how to find a vein. The progression is incremental. Smoking becomes snorting, becomes injecting, but the destination is the same. First responders begin encountering overdoses in places they never expected: suburban homes, college campuses, church parking lots. The victims are young and old, male and female, employed and unemployed. The only common thread is that most of them started with a prescription from a doctor they trusted for pain that was real. The bridge from Percocet to heroin is short and well-traveled. It's paved with good intentions, corporate greed, regulatory failure, and the simple, brutal logic of addiction and economics. And by 2015, tens of thousands of Americans have already crossed it. Tens of thousands more are on their way. And just when doctors, police, and families think it can't get worse, just when heroin seems like the bottom, a new killer emerges from the shadows, one that makes everything before it look almost merciful by comparison. Fentanyl is a synthetic opioid, 50 to 100 times stronger than morphine and 30 to 50 times stronger than heroin. To put this in perspective, a dose of heroin the size of a few grains of salt would have little effect. That same amount of fentanyl could kill. The drug itself is not new. It was first synthesized in 1960 by a Belgian chemist named Paul Janssen, who was searching for a powerful, fast-acting painkiller for use in surgical anesthesia. Fentanyl was perfect for that purpose: potent, predictable, with a rapid onset and relatively short duration. For decades, it remains where it belongs, in operating rooms and cancer wards, administered by trained medical professionals in carefully measured doses. It saves lives. But by the mid-2010s, fentanyl has escaped the hospital. It's being mass-produced in clandestine laboratories in China, shipped to Mexican drug cartels, and then smuggled across the US border. From there, it enters the American drug supply, and the death toll begins to climb at a rate that defies comprehension. The economics driving this shift are ruthless and simple. 1 kilogram of heroin purchased wholesale costs approximately $50,000 to $80,000. 1 kilogram of pure fentanyl, produced for roughly the same cost, can be cut and diluted to create the equivalent of 50 kilograms of street-level heroin product. The potential profit is exponentially greater. But the numbers become even more staggering when you consider lethality. A single kilogram of fentanyl contains enough lethal doses to kill approximately 500,000 people. And because fentanyl is so potent, it's far easier to smuggle than heroin. A package the size of a bag of sugar, easily concealed in luggage or shipped through the mail, can supply a regional drug market for weeks. The contamination of the drug supply begins gradually around 2015, then accelerates with horrifying speed. At first, fentanyl is used as a cutting agent, mixed into heroin to stretch the product and increase its potency. Dealers can sell stronger heroin while using less actual heroin. For cartels and mid-level distributors, it's a straightforward business decision. But the margin for error is microscopic. Fentanyl is difficult to mix evenly into heroin powder. A bag might contain mostly heroin with a small cluster of fentanyl particles. One user might inject from the bag and experience a normal high. The next user, drawing from a spot with higher fentanyl concentration, might stop breathing within seconds. Users have no way of knowing what they're injecting. They prepare their usual dose, the amount they've used dozens or hundreds of times before. They inject it, and then their breathing stops. Many are found with the needle still in their arms, dead before they could even withdraw it. Then the cartels make a calculated decision. Why bother with heroin at all? Fentanyl is cheaper to produce, easier to transport, and more profitable. They begin pressing fentanyl
powder into counterfeit pills designed to mimic legitimate pharmaceuticals. The counterfeits are expertly made, stamped with the same logos, the same numbers, nearly indistinguishable from real Percocet, Vicodin, or Xanax. A teenager with a sore back, buying what they believe is a single Percocet from a friend or through social media, has no idea they're holding illicit fentanyl. They swallow it, expecting relief. Instead, their heart stops. These deaths are different from the heroin overdoses that came before.
Heroin users knew they were using an illegal drug. They understood the risks, however dimly. But people taking what they believed to be pharmaceutical pills, pills that looked identical to ones they or their parents had received from a pharmacy, have no warning, no preparation, no chance. As if fentanyl itself weren't deadly enough, chemists begin producing fentanyl analogs, slight chemical modifications that produce similar effects but evade drug enforcement laws. Acetylfentanyl, furanylfentanyl, and most terrifying of all, carfentanil. Carfentanil is an elephant tranquilizer used by veterinarians and wildlife managers to sedate large animals. It's 10,000 times more potent than morphine and 100 times more potent than fentanyl. A single microgram, an amount invisible to the naked eye, can be lethal to a human. In 2016 and 2017, carfentanil begins appearing in the drug supply in certain regions, particularly in the Midwest. The overdoses are almost instantaneous. Users collapse within seconds of injection. Emergency responders find that standard doses of naloxone, the opioid overdose reversal medication, are often insufficient. They have to administer multiple doses, sometimes 5 or 6, and even then, revival is not guaranteed. The death toll from synthetic opioids tells a story of escalating catastrophe. In 2010, approximately 3,000 Americans die from synthetic opioid overdoses, mostly pharmaceutical fentanyl. By 2015, that number has climbed to around 9,500. By 2017, it's 28,000. By 2021, it exceeds 70,000. To put this in perspective, synthetic opioid deaths alone now surpass annual fatalities from car accidents, gun violence, and even the peak of the HIV/AIDS epidemic in the early 1990s. This is one category of drug in one country in 1 year. The deaths are faster, more sudden, more unpredictable than anything that came before. Experienced heroin users with high tolerance are dying. First-time teenagers experimenting with what they thought was a prescription pill are dying. People who think they're using cocaine or methamphetamine, drugs that have also become contaminated with fentanyl, are dying. The geographic spread is total. Cities, suburbs, rural communities, no place is spared. Emergency rooms that once dealt with a handful of overdoses per month are now seeing multiple overdoses per shift. First responders become grimly accustomed to reviving the same individuals repeatedly, sometimes multiple times in a single week. Naloxone becomes ubiquitous, distributed to police officers, firefighters, librarians, and family members. Naloxone saves lives, there's no question about that, but it's not a solution. It reverses an overdose in the moment, but it does nothing to address the underlying addiction. People revived with naloxone often return to using within hours, sometimes immediately. The cycle continues. What makes the fentanyl crisis particularly insidious is its randomness. With prescription pills, users at least knew what they were taking: the dose, the formulation, the expected effects. With heroin, it was risk, but experienced users developed a sense of their tolerance, their limits. With fentanyl-contaminated drugs, all predictability vanishes. One bag might be safe, the next from the same dealer might be lethal. One pill might contain no fentanyl, the next might contain enough to stop your heart. It becomes a form of Russian roulette, played daily by hundreds of thousands of Americans who were introduced to opioids through a prescription from a doctor, for pain that was real. The pathway from Percocet to fentanyl is now well established and terrifyingly efficient. But statistics, no matter how staggering, can numb us to the reality of individual suffering. The numbers, 58 million prescriptions, 70,000 deaths, 80% of heroin users, become abstractions. So let us make this concrete. Let us talk about 3 people. Sarah was 17 when she tore her ACL during a high school soccer championship game. She was a star player, a team captain, with a full athletic scholarship waiting for her at a Division I university. The surgery to repair the ligament was successful, routine. Her orthopedic surgeon sent her home with a prescription for 60 tablets of Percocet, 10 milligrams each. 1 to 2 tablets every 4 to 6 hours is needed for pain. For the first few days, the pills did exactly what they were supposed to do. They relieved the pain. Sarah could
Sleep. She could elevate her leg and ice it without wincing at every movement. But the pills did something else, something she hadn't expected and didn't fully understand. They eliminated her anxiety.
The pressure about returning to play in time for the next season. The stress about maintaining her grades. The grief over her grandmother's recent death. The social pressures of being 17. All of it, softened, muted, bearable. She felt warm, safe, content, better than content. By the time her prescription ran out 2 weeks later, she was taking more than the surgeon had directed. Not dramatically more, just an extra pill here and there. When she went back for her follow-up appointment, she mentioned that the pain was still significant. The surgeon, wanting to help, prescribed 30 more tablets. He told her this would be the last refill, that she should transition to over-the-counter medications. Sarah tried, she really did, but 36 hours after taking her last pill, she felt terrible, achy, anxious, unable to sleep. She didn't connect it to the pills. She thought she was getting sick or that the stress was catching up with her. When she started college that fall, her anxiety and depression came roaring back, worse than before. A teammate, noticing her distress, offered her a Percocet. For the pain, she said. Sarah took it. The relief was instant, overwhelming. Within a semester, she was buying pills from a dealer near campus, $5 to $10 per pill, $50 to $100 a day to feel normal, to function, to get through classes and practice. Her scholarship evaporated. She dropped out. She went home, but she couldn't afford the pills anymore. That's when someone introduced her to heroin. It was cheaper, stronger, easier to find. 3 years after her ACL surgery, Sarah died of a fentanyl overdose in a friend's apartment. She was 23 years old. Sarah's story is not unique. It is the template. Michael was 52, a construction worker with 3 kids and a mortgage. He threw out his back lifting a steel beam on a job site. The pain was debilitating. He couldn't work, couldn't sleep, could barely walk. His doctor prescribed Percocet, 10 milligrams, 1 tablet every 6 hours. It worked beautifully. Within days, Michael was back at work, playing with his kids in the evening, sleeping through the night. When the prescription ended after 2 weeks, the pain came roaring back. But it was worse now, sharper, more widespread. What Michael didn't know was that he was experiencing opioid-induced hyperalgesia, a condition where the drugs themselves increase the nervous system's sensitivity to pain. His doctor, increasingly cautious amid growing scrutiny of opioid prescribing, suggested physical therapy. Michael tried it, but it didn't help fast enough. He needed to work. He had bills to pay. He found another doctor, one more willing to prescribe, a month's supply, then another month, then another. This became doctor shopping, seeing multiple physicians to obtain overlapping prescriptions. Michael supplemented with pills from a coworker who had his own surplus. He told himself it was temporary, just until his back healed properly. Then came the DEA crackdowns. Doctors became afraid. Pills became scarce and expensive. The same coworker who had sold him Percocet offered him something else, crushed OxyContin that could be snorted for a faster, stronger effect. Michael resisted at first, but the pain was unbearable, and the pills were running out. When OxyContin was reformulated to be crush-resistant, the coworker offered heroin. It's cheaper, stronger, same thing really. Michael never thought of himself as a drug addict. He had a job, a family, responsibilities. He was just managing pain, real, debilitating pain that had started with an injury that happened while he was working to provide for his children. He died in his truck in a Home Depot parking lot, a needle in his arm, surrounded by lumber he had just purchased to build a deck for his family. Jessica was 41, an emergency room nurse who worked night shifts. She understood opioids. She had seen the destruction they caused. She had treated countless overdoses, held the hands of dying addicts, comforted grieving families. When she began experiencing severe recurring migraines, the kind where light and sound become unbearable, where the pain makes it impossible to think or function, she resisted medication for months. But eventually, the migraines became too frequent, too intense. She accepted a prescription for Percocet. She was careful. She took it exactly as prescribed, only during a migraine, never more than the recommended dose. She was a healthcare professional. She knew the risks. But the migraines became more frequent, or perhaps she became more aware of them. The Percocet went from an occasional necessity to a regular part of her life. After 6 months, she realized something terrifying.
Couldn't stop. She tried. The withdrawal wasn't just physical, the aches, the insomnia, the nausea. It was the psychological certainty that she could not function without the pills, that she would not be able to work her shifts, care for her patients, drive home safely. So she started taking pills from the hospital, just a few at a time, just enough to avoid withdrawal between prescriptions, to keep working, to keep functioning. She told herself it was temporary, that she would taper off once things settled, once the migraines were under control. She was caught during a routine medication audit, narcotic log discrepancies, an investigation. Jessica lost her nursing license. She lost her career, her identity, the work she had devoted 20 years of her life to building. She is alive now, in recovery, but she will never practice nursing again. Her addiction started with a legitimate prescription for a legitimate medical condition. It progressed despite her doing everything right, despite her knowledge and caution, and it still cost her everything. These three people, Sarah, Michael, Jessica, represent three different entry points into the same nightmare: a teenager with an athletic injury, a middle-aged worker with back pain, a healthcare professional with migraines. Different ages, different circumstances, different levels of knowledge about the risks. But the pattern is the same: a legitimate prescription, pain relief that came with something extra, emotional relief, anxiety reduction, a sense of okayness that had been missing, dependence that developed faster than anyone anticipated, a prescription that ended, but a need that did not, escalation, desperation, heroin, fentanyl. The Centers for Disease Control and Prevention will tell you that 4 out of 5 people who use heroin started with prescription opioids, but that statistic doesn't capture the individual tragedies, the lives interrupted, the potential unrealized, the families shattered. These stories, Sarah's, Michael's, Jessica's, are not exceptional. They are the pattern. Between 1999 and 2021, more than 280,000 Americans died from prescription opioid overdoses specifically. When you include heroin and synthetic opioids like fentanyl, the drugs that so many turn to after prescriptions ran out, the total exceeds 700,000 deaths. To understand the scale of this loss, consider this: the United States lost approximately 405,000 service members in World War II. Vietnam claimed roughly 58,000 American lives. At the peak of the AIDS epidemic in the 1990s, the disease killed about 50,000 Americans per year. The opioid crisis has killed more people than all United States combat deaths in every war since World War II combined. But the numbers alone cannot capture the full scope of the devastation. They don't count the 2.7 million Americans currently living with opioid use disorder, trapped in the daily struggle of addiction. They don't count the hundreds of thousands of children in foster care because their parents overdosed or became incapacitated. They don't count the families bankrupted by the costs of treatment, legal fees, and lost income. They don't count the communities that collapsed, entire towns in Appalachia and the Rust Belt where the working-age population became so incapacitated that local economies simply ceased to function. If there is a lesson to be drawn from this catastrophe, it is this: there are no miracle drugs. Every powerful medicine carries risk. The promise of a pain-free existence, aggressively sold and enormously profitable, was a lie. It is the same lie Bayer told about heroin in 1898, just in different packaging with different branding. Pain is part of the human condition. Attempts to eliminate it entirely through chemistry alone, without addressing the underlying physical, psychological, and social causes, will always fail. And the failure is measured in graves. The history of Percocet is not separate from the history of OxyContin, heroin, and fentanyl. It is one continuous story, one long betrayal. A story of pain and profit, of science twisted by commerce, of trust exploited on an incomprehensible scale. The little white pill was not an accident. It was a choice, a series of choices made by people who knew, or should have known, what would happen. Choices made in corporate boardrooms and research laboratories, in doctors' offices and pharmacies, in regulatory agencies and legislative chambers. The cost of those choices, the lives lost, the families destroyed, the communities hollowed out, will be paid for generations to come. The shadow is long, the reckoning is incomplete, and the bodies keep piling up. If this video helped you learn something or helped you sleep, please consider leaving a like and subscribing. Share it with someone who might benefit, and thank you for watching. Rest well.